Cardiac electrical pathophysiology. So before we dive in, let's break down that title because Lord knows I had to look that up when Dr. Schaefer told me that this was my topic. There are three very big words up there. First up, cardiac. I really hope by this point in the semester we all know that cardiac means of or pertaining to the heart. Second, electrical. Using our advanced academic minds and critical thinking skills, we know that we are most likely talking about the conduction system here. So far, we've got the conduction system of the heart. Finally, pathophysiology. Path means affected by disease, physio is physical or natural, and of course, ology is the study of. Therefore, pathophysiology is the study of diseased physiology. Putting it all together, we have the study of the diseased conduction system of the heart, i.e., cardiac electrical pathophysiology. But wait, haven't we been talking about that in different ways all semester? Yeah, sorta. To be even more specific here, we're talking about pacemakers and ICDs. I won't spoil the surprise on what that stands for just yet. Before we go forward, we have to go backward, all the way back to when the dinosaurs roamed the earth. Just kidding. Back to the 1950s. Pacemakers were initially used to treat symptomatic bradycardia. The key word here is symptomatic. This means bradycardia, the heart rate is less than 60 beats per minute, coupled with symptoms. This can be a serious problem in older adults who are likely not running marathons to increase contractility and stroke volume, to elicit this as a training response. In this case, slowed heartbeat can lead to pre-syncope, feeling lightheaded, syncope, actually fainting, fatigue or tiredness, shortness of breath, angina or chest pain, confusion, a common feeling among college students, and exercise intolerance. Moving up to the 1960s, we had cavemen at this point. Pacemakers were built to treat atrioventricular blocks. Additionally, in 1969, pacemakers were made to use lithium batteries, which extended the life of the pacemaker so the patient did not need as many replacements and resolved previous restrictions, such as needing a wall outlet to operate circa 1950. Today, pacemakers are able to regulate hemodynamics of the blood during exercise and at rest, thus providing oxygen to the rest of the body and maintaining a steady rhythm. Why do we, as exercise physiologists, or those of us looking to go into cardiac rehab, care? Because when someone enters your cardiac rehab facility, you as the clinician need to know how the pacemakers mimic normal heart rhythm and conduction. The clinician needs to know what the settings are and how they change the response the pacemaker will have to increased activity or heart rate. From these things, an observation the clinician makes, the clinician, again, that's you, will make a judgment call on whether or not the settings are appropriate or need to be altered to better compensate for the patient's desired level of activity and the patient's heart's response to stimuli. The type of pacemaker your patient has will affect the type and level of exercise that they are able to do and that's safe for them. You wouldn't want to put someone in jeopardy because you pushed them too hard, and you wouldn't want to impede their progress through rehab and back to a more normal life because you didn't know the kind of pacemaker that they have. Another often neglected reason to care is patient education. Oftentimes, rehab is where the patient learns how to live with their new gear, and you need to be knowledgeable about it and able to answer any questions that they may have. Or, the short answer, because I said so. What are we specifically talking about when we say someone needs a pacemaker? Or who even could possibly need a pacemaker? Well, typically when someone needs a pacemaker, it is for regulating heart rate, as previously mentioned, synchronizing the chambers, remember the atria and the ventricles, in patients with congestive heart failure, more on that later, or in the case of life-threatening arrhythmias like ventricular tachycardia or ventricular fibrillation. Remember the St. Louis Blues player earlier this season? He collapsed mid-game and was taken to the hospital with such life-threatening arrhythmia. He was only in his 30s. Bearing that in mind, however, most people who need a pacemaker are 65 or older and are equally distributed between males and females. As of today, more than 100,000 pacemakers are implanted every year, and with our aging population, that number is only expected to rise. However, sometimes infants need pacemakers due to sick sinus syndrome, heart failure, or congenital heart defects. Diving right into the meat of the material here, we all know that the heart normally beats 100,000 times a day at a typical resting rate of 60 to 100 beats per minute, with impulses beginning in the sinoatrial node, traveling through Bachmann's bundles through the atria. That will be on the test. No, it is not written in the notes. You might want to write that down. To the atrioventricular node, down the bundle of His, through the bundle branches, and terminating in the Purkinje fibers all throughout the ventricles. But what if it doesn't? What if the signal gets stopped? Or the SA node just can't cope? If the signal from the SA node goes out, or the SA node gives up, or doesn't convey enough of a depolarization signal, then you get a collection of rhythm disorders known as sick sinus syndrome, or SSS. This generally means that the SA node is unable to generate a heartbeat or increase the heart rate when metabolic demands change. I was on Reddit the other day because I'm a nerd, and one of the top posts for r/EKGs was 2 EKG strips taken 30 seconds apart. One looked relatively normal, granted with sinus tachycardia and a slightly shortened PR interval. The second one, however, showed a ventricular escape rhythm. Remember that the ventricular rate is 20 to 40 beats per minute. This rhythm strip had a heart rate of 29 beats per minute and evidence of potential bundle branch block in the limb leads. I say potential because due to the slow rate, I would want another read printed, since this one only showed one waveform per lead aside from the rhythm strip. The diagnosis was sick sinus syndrome. The patient's SA node was unable to compensate for an increased demand for blood and oxygen due to a change in position or their attempted cardiac rehabilitation exercises. So that's just one example of a rhythm disorder under the sick sinus syndrome umbrella. These can include sinus bradycardia, as I've just mentioned, sinus tachycardia, the heart rate goes too fast, over 100 beats per minute, alternating sinus tachycardia with sinus bradycardia, also known as tachybrady syndrome, or the heart rate pauses or stops, known as sinus arrest. Sick sinus syndrome is typically due to scar-like damage on or around the SA node from previous surgeries or breakdown of heart muscle due to age. This is usually seen in people older than 50 who have a number of risk factors, such as congenital heart disease, coronary artery disease, or high blood pressure. In children, SSS can be caused by damage caused from previous heart surgery or is a congenital defect. Certain medications can also mimic SSS. Another cause for needing a pacemaker is atrioventricular block. Typically, first or second degree AV blocks do not require a pacemaker. Third degree or complete heart block may require one. If the block in question is determined to need a pacemaker, this will be due to the AV dissociation, which means the atria and the ventricles are now operating out of sync at their own intrinsic rates. They are completely separate, completely independent of each other. AV blocks occur when there is a slowing or a stoppage of the electrical signal at the level of the AV node, or in complete heart block, there may be a block lower on the bundle branches too. This may be due to a congenital malformation, damage from surgery or myocardial injury, coronary artery disease, myo or endocarditis, or idiopathic fibrosis, among other things. If it is the third degree block that does not require a pacemaker, a common cause for that is Lyme disease. Just a fun little fact for you if you weren't already afraid of ticks. Now, I said previously that third degree block would require a pacemaker. However, it is worth making a note that second degree Mobitz type 2 block can progress to third degree block, which makes a pacemaker more of a necessity. We all remember that Mobitz is the block on the rhythm strip that is a normal beat followed by a P wave with a dropped QRS in various ratios such as 2:1 or 3:2, right? Of course you all remember that. The second degree block, known as Wenckebach, I can't spell that, I'm sorry, typically does not require a pacemaker as it does not progress to third degree. Now that we know when a pacemaker may be required, we should talk about the nuts and bolts of the pacemaker itself. What is normally referred to as the pacemaker is the pulse generator, which is housed in a small box about the size of a matchbook. Within the box, we can find the batteries, typically lithium-ion batteries today, and circuitry controlling the pulses, hence pulse generator, and any additional modifications, such as accelerometers or vibration sensors. Additional components are the pacing leads, which are insulated wires with at least one electrode on the end. There can be as few as one wire or as many as 3. The insulation around the wires is important to reduce burns, which were fairly common with early forms of pacemakers. These leads tend to be pretty flexible to allow for range of motion and activity. You wouldn't want to raise your arm and rip out a lead wire by accident. And I'm sure we can all use our critical thinking skills to figure out that the electrodes on the ends of the lead wires are to deliver the pulse to the appropriate location in the event that one is needed. So we've got a pacemaker, and we know the patient needs one. It's time for surgery. Get gowned and gloved. To implant the pacemaker, the surgery is typically done by surgeons or cardiologists in a short 1-hour surgery. After the surgery, it is highly advisable that the patient remain in the hospital for at least 1 day of post-op monitoring. A patient in Grey's Anatomy did not do this and ended up being discharged, having a coughing fit at home, and dislodged one of her lead wires. It is at this point the leads are most likely to slip off from where they're supposed to be. The pulse generator is typically placed just under the collarbone, either subcutaneously or intramuscularly, and the lead wires are fed through a vein down to the heart, where it is then positioned either on the heart surface or within the heart itself. Once the pacemaker is in the body, the pacemaker's settings can be adjusted externally using radio frequencies and a receiver placed on the patient's chest. Additionally, post-op, there may be some movement restrictions even after the patient leaves the hospital to ensure the leads do not get dislodged before they're healed up and secured. In general, there are 2 classes of pacemakers: a temporary external pacemaker and a permanent pacemaker. The temporary pacemakers are used in the event that a person needs a pacemaker implanted, but one is not available, or the patient is suffering from a transient condition, such as one caused by medication, that does not require a permanent pacemaker to be implanted, or it is a life or death emergency. Permanent pacemakers can be further divided by the number of chambers they possess. There are single chamber and dual chamber pacemakers. The single chamber pacemakers are typically placed in the right atrium or the right ventricle, typically in the right ventricle. These pacemakers are typically used to correct for bradyarrhythmias, when the SA node is sending out signals just way too slowly, and the lower conduction system, so the AV node, the bundle of His, the bundle branches, and the Purkinje fibers are all still fully intact. A dual chamber pacemaker is different from the single chamber in that it uses at least 2 leads, one in the right atrium and one in the right ventricle. This allows for the dual chamber pacemaker to send electrical pulses to either of the chambers. This is the type typically used when there is some sort of block in the conduction system to the ventricles, so that AV block we were talking about earlier. In both types, there is a sensor in the pacemaker that detects either vibrations or accelerations, or both. This allows the pacemaker to adjust its pacing to help the heart cope with increased demands due to movement. More on that in a little bit. With these types of pacemakers come a variety of settings, which begs the question: how do you, as a clinician, know what these settings are if the pacemaker is inside the body? You can't visually examine it. Well, each pacemaker will have a letter code to tell you what kind of pacemaker it is. Isn't that so convenient? The first letter refers to the chamber of the heart that is being paced by the lead. It will be represented by an A for atrium, V for ventricle, D for dual, or 0 for none. The second letter refers to the chamber of the heart that the lead is sensing. Again, this will be A for atrium, V for ventricle, D for dual, and 0 for none. The third letter refers to the response a pacemaker will have to a sensed event, such as an increase in heart rate or an arrhythmia. This will be represented by a T for triggered, I for inhibited, or D for dual. The fourth letter represents the response a pacemaker will have to various rates, such as an accelerometer or a rate response. This will be represented by R. The last letter is any anti-tachycardia features. So a pacemaker with the lettering of D, 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 for example, would be a pacemaker that is sensing both the atria and the ventricles and is pacing both the atria and the ventricles and will have a dual response should a shock be needed. Typically, the goal of a pacemaker is to emulate the heart's natural rhythm. To do that, a dual chamber pacemaker will typically be placed in the right atrium to sense the SA node's impulse and will trigger a response below the AV node's block to facilitate a ventricular contraction in a pretty close replication of a natural rhythm. Along with that feature, there are several other key features that pacemakers have. These include physiological pacing, mode switching, and rate-responsive pacing. Physiological pacing focuses on the AV timing interval. This allows for as close as possible a delay to mimic a normal rhythm and still give enough time for filling. This sweet spot is around 150 milliseconds in a normal person. This rate can also be set based on heart rate to compensate for normal shortening of the AV interval during exercise. Maintaining the synchrony between the atria and the ventricles allows for the maintenance of other physiological variables, such as stroke volume, heart rate, and blood pressure. Mode switching is commonly used when the patient suffers from an atrial arrhythmia, such as atrial fibrillation, one of the most common arrhythmias. When mode switching is turned on, this causes the pacemaker to go from pacing the atria to pacing the ventricles, should an abnormal atrial rhythm occur. This allows the pacemaker to maintain a continuous rhythm in the ventricles, preventing them from following the atria into fibrillation. A sub-feature of mode switching is maximal tracking rate. This means that the pacemaker can be programmed not to switch to ventricular tracking if it picks up only one or two stray atrial beats. It can be set so the pacemaker will only switch if it picks up a certain number of missed beats. Finally, the rate-responsive pacing. I'll give you a guess as to what that means. I've been indirectly referencing this one the entire time. It's relatively new compared to the other two, but rate-responsive pacing is when the pacemaker senses the body's changing demands for oxygen and need for a greater cardiac output. These pacemakers really changed the game in cardiac rehab for chronotropic incompetence in these patients. We all remember that chronotropic incompetence is failure of the blood pressure or heart rate to rise in response to increasing metabolic demand. This feature allows for the patients to exercise at a higher capacity than their native SA node would be able to keep up with. They are particularly good for younger patients who may be pushing to the upper reaches of their limits. So, how do these pacemakers do this? As I've mentioned before, some pacemakers have accelerometers that can detect movement in the anterior and posterior direction, so front to back. Furthermore, these pacemakers have vibration sensors that utilize piezoelectric crystals that detect vibration created by the muscles during movement. Again, why would we as practitioners need to be aware of these things? Again, it's about the settings. If you have a patient who's having shortness of breath going up or down the stairs and they have a pacemaker, then the settings probably need to be adjusted to meet that patient's need and give them as normal a life as you possibly can. So how do you know if the heart rate is appropriate for the patients with a rate-responsive pacemaker? That's where exercise testing comes in. And no, I do not mean take Granny, who has just recovered from heart surgery, and throw her into a Bruce protocol max test. Granny may not even need a formal test. Exercise testing is important because it allows the clinician, that's us, to determine if the settings are appropriate, as mentioned before. It helps to determine the anginal threshold, at what intensity of exercise or activity causes the patient to have chest pain, and it allows for the assessment of chronotropic incompetence. Here you'll see a table with exercise protocol on it. Please note the MET levels. Remember, the metabolic equivalence units. These are the activity levels each stage will elicit. Metabolic equivalence units needed for activities of daily living are around 5 METs. In this protocol, it takes 5 whole stages to reach that level. The Bruce protocol starts out at 4.2 METs and jumps in the next stage all the way up to 6 METs. Take a moment and think about what that tells you about this population. Now, there are, of course, exceptions. The St. Louis Blues player I mentioned earlier probably did not perform a chronotropic assessment protocol like this one. But Granny, who's 90 years old, might. Now, knowing Granny is 90 years old, you may decide to forego a formal test entirely, which is fine, but to assess the workings of the pacemaker, you may need to perform an informal test, such as a 6-minute walk test. This is simply having the patient walk for 3 minutes at their own pace, followed by a walk for 3 minutes at a brisk pace, and assessing their heart response. What do they say? How do they feel? Now, this is where the super cool pacemaker tech comes in. Some pacemakers can store data, and Granny wouldn't even need to be hooked up to an EKG machine. The doctor may be able to pull data straight from the pacemaker itself and determine if it's working appropriately. From your exercise testing, or not, you, the clinician, will be able to provide an exercise prescription. Harkening back to EXS 412, I hope you remember the FIT principle: frequency, intensity, time, and type. In this population, just like most populations, we would want them at 5 times a week for moderate intensity exercise and 3 to 5 times a week for higher intensity. We don't ever want them to exceed 85% of their VO2 max, however. The recommendations for time are 20 to 60-minute bouts. Mode or type is very important here because, as previously mentioned, some forms of exercise, such as climbing the stairs, are tricky to get the pacemaker settings just right because they do not create large variations in the forces, such as treadmill protocols with increasing grade but not speed. Increasing the grade would require a higher Q, or stroke volume, but not increasing the speed will not increase the amount of muscular vibrations. Additionally, there are practical considerations as well. A patient with a pacemaker should be discouraged from contact sports due to the risk of damaging or dislodging the pacemaker. Unfortunately for Jay Bowenmeister and his ICD, this may be the end of his NHL career. Treadmill walking and cycling are fairly common and safe options. Now, I want to reiterate the intensity guidelines. This is especially key for pacemakers. Ideally, you would want the patient between 40 to 85% of their VO2 max. But keep in mind, this is typically an older population who may have other comorbid conditions that would contraindicate that. And the type of pacemaker that they have, this may not always be feasible. For pacemakers that are not rate responsive, but are fixed rate type pacemakers, a better option would be to carefully monitor the intensity using the RPE and MET scales. We do not want the patient to go over the 85% intensity or increased heart rate past a certain point, as that may facilitate a shock being delivered when one is not necessary. Another key consideration is the hemodynamic response. If for any reason there is a failure of the blood pressure or heart rate to rise during increasing intensity, do not continue. Stop the exercise. It is okay. The patient's safety must come first. Wow, we made it. We are all the way through pacemakers. Take a deep breath, because now we're moving on to ICDs. I know you've been sitting on the edge of your seat with bated breath, just dying to know what an ICD is. I shall relieve you of that stress now. An ICD is a subtype of a pacemaker. ICD stands for internal cardioverter defibrillator, also known as an AICD, or automatic internal cardioverter defibrillator. All right, let's figure out what all that means. We know this is another internal device, but what about cardioversion and defibrillation? Well, here's where it gets a little bit more murky. We've all had CPR training by this point in the exercise science program, hopefully, and we learned about AEDs, automatic external defibrillators, which is a machine that reads the patient's EKG and delivers a shock to restart the heart appropriately. In my mind, that's what I think of when I think of defibrillation. Now, when you Google cardioversion, the first definition you see is it's a means of resetting the heart using shocks or drugs. We know in this case we're talking about shocks. So what is the difference? The difference between cardioversion and defibrillation is at what point during the cardiac cycle the shock is delivered. Cardioversion is synced with the QRS complex, whereas defibrillation is not and will deliver a shock wherever it wants in the cardiac cycle. There are several other differences as well, such as the voltage that is required. Does the patient have a pulse? Are they hemodynamically stable or unstable? But this is the key difference that helps distinguish them in my mind. So now that we're clear on that, we can move on. Who would need an ICD over a pacemaker? Patients that get an ICD over a pacemaker are typically patients who have potentially lethal ventricular tachycardias or have survived a sudden death event. Yeah, you heard that correctly. They survived a sudden death event. Additionally, these patients may be high risk for reoccurring cardiac arrest or are at high risk for cardiac arrest due to myocardial injury. Similarly to pacemakers, ICDs are inserted in the body, either under the skin or under the muscle, typically around the collarbone or occasionally into the abdomen. And the lead wires are placed in the heart or on the heart's surface through a vein. In a recent development, some pacemakers or ICDs can act as both, depending on what the device senses. Due to the nature of this population that typically, but not always, receives these devices, there are a few special considerations that must be taken into account with these patients who have an ICD. These older patients may have other pre-existing comorbidities, which limit their ability to exercise. This means that when you throw your patients on the treadmill or the bike, you had better be watching them closely for any exercise-induced changes that may warrant stoppage of exercise or adjustment of their device's settings. These would include anginal pain, shortness of breath, an abnormal hemodynamic response, among other things. Exercise recommendations for this population also have to be carefully considered, and physicians are encouraged to set firm limits on the intensity of exercise due to the desire to keep the heart below the shock threshold. Interestingly, this subset of patients have restrictions on operating a motor vehicle. I can't imagine why that might be in there. It seems perfectly safe to have someone who may become unresponsive or receive a shock to the heart to be out on the roads. All kidding aside, there is a guideline that recommends patients do not drive between 3 and 6 months of the last event that triggered a shock. All precautions aside, the benefits of ICDs far outweigh the restrictions. These include alleviation of symptoms, improvement of cardiac response, improved quality of life, improved functional capacity, extended life, and exercise participation. With all of that, there is another option for patients with congestive heart failure, a la Denis Duquette, to improve the functioning of their hearts while on an ICD or pacemaker. I don't believe that Denis ever had an ICD implanted, but he had heart failure, so it still counts. This therapy is known as cardiac resynchronization therapy, and it is used in an attempt to resynchronize the beating of the atria and the ventricles that may be caused by left bundle branch block or other intraventricular block that results in severe slowing of the conduction system. This delay causes severe dyssynchrony that can lead to sudden death due to lack of oxygen being delivered. In order for CRT to work, to improve ejection fraction, reduce mitral valve regurgitation, and reverse left ventricular remodeling, the ICD leads stimulate the ventricles to contract together. Before I go any further, ventricular remodeling is the process that happens during heart failure that leads to that really dilated, thickened heart muscle. Reversing ventricular remodeling is an improvement back to a more normal looking heart. In this case, reversing the remodeling of the muscles is a good thing. Patients that present this have better outcomes than patients that do not. Anyway, CRT allows this to happen by creating a more efficient environment for the heart to recover. Now, this is not a magic pill that fixes heart failure, but it can greatly improve the outcomes of these patients, such as quality of life and longevity. Okay, take a deep breath. We've made it to the end. To recap briefly, cardiac electrical pathophysiology is the study of the diseased conduction system of the heart and how we fix it with pacemakers and internal cardioverter defibrillators. Pacemakers can be needed by anyone, but are most common in older populations due to an aging conduction system or other risk factors such as coronary artery disease and high blood pressure. Pacemakers are needed when there is a serious problem in the conduction system, such as symptomatic bradycardia, remember the syncope, presyncope, shortness of breath, anginal pain, etc., or third degree AV block, when the signal from the SA node is unable to pass through the atrial ventricular node to facilitate ventricular contraction. Pacemakers are composed of 3 main parts, or 4 or 5, depending on how you want to think about it. The main pulse generator, which can be broken down into the circuitry, the batteries, the lead wires, which go through the vein down to the heart, and the electrodes, which are inserted or sewn on top of the heart muscle in a very brief surgery. Pacemakers can be either single or dual chambered, and the type is represented by a series of letters. Single-chambered pacemakers are typically placed in the right ventricle, whereas dual pacemakers are placed in both the atria and the ventricles. These dual-chambered pacemakers can deliver a pulse to either location. There are several key features of the pacemaker, which include physiological pacing, mode switching, and rate-responsive pacing. Physiological pacing refers to keeping the timing between the atrial contraction and the ventricular contraction as close to that sweet spot of 150 milliseconds or normal as possible, while still allowing for AV shortening during exercise. Mode switching allows for the pacemaker to switch from pacing the atria to pacing the ventricles should an abnormal rhythm be detected. And the newest, most shiny, bestest innovation to the pacemaker and the most relevant to the exercise physiologist because it allows patients to exercise at a higher capacity is the rate-responsive pacing, which allows the pacemaker to deliver pacing when the patient has exceeded the capability of their native SA node. We also talked about ICDs, which are internal cardioverter defibrillators that deliver shocks to the heart in the event of an abnormal, life-threatening arrhythmia. cardioversion and defibrillation are fairly similar. However, the key difference between them is cardioversion will shock the heart in sync with the QRS complex, whereas defibrillation will shock at any point during the cardiac cycle. ICDs are, in general, fairly similar to pacemakers in most aspects. When prescribing exercise or exercise testing, always keep in mind the patient and their comorbidities. Ideally, as exercise experts, we would like to get the patient exercising 3 to 5 times a week at a moderate intensity for between 20 to 60 minutes. Cardiac resynchronization therapy is a relatively new treatment option for those patients with heart failure that can help improve the synchrony of their atria and their ventricles to allow them to have reduced mitral valve regurgitation, improve their ejection fraction, and promote reversal of ventricular remodeling. This allows these patients to have a reduced risk of sudden death due to a lack of oxygen. Questions? Comments? Third grade jokes? No? Good. I'm going to take a nap.